Okay, welcome everybody. And this is always fun to do Health Talk because we learn new and exciting things and meet really cool people. Dr. Berdett Faussett is, let me see if I can get this right now, okay? Because I want to make sure the doctor standing right here, a maternal fetal medicine specialist, perinatologist, right?
Right.
Did I get that right?
Perfect.
Okay, I'm going home now.
Yeah. Yeah, you should.
Okay,
You got an A.
So tell us exactly what all this means to the layman like us.
To the rest of us?
Yes.
Well, so maternal fetal medicine, two big parts to that. There's the mom side and the baby side. So maternal fetal medicine docs are OBGYNs. So after the normal 4-year medical school training, then 4 years of OBGYN training. Then it's another 3 years of subspecialty training or fellowship training in maternal fetal medicine. Basically take care of women with complicated pregnancies. So there's two focuses. You could have moms that have particular medical complications. Diabetes is a classic example, or thyroid problems, or cardiac disease, or multiple sclerosis, any number of medical conditions. And then there's the baby side. So that's the maternal and then the fetal. And the baby side, babies with abnormalities, genetic or structural problems, so moms and babies, multiples. Take care of moms with higher order pregnancies, we call them, when they have 2 or 3 or 4 or that kind of thing.
So what is the most complicated surgery you've had to do?
Well, I guess that depends. Are you talking mom or baby?
Well, how about one of each?
I guess
yeah.
the combination would
yeah.
probably jump up the level of difficulty,
wow.
right?
I think from the maternal perspective, I guess some of the more interesting, rewarding procedures. I guess we all do as an OBGYN and as an obstetrician. I certainly have been there for lots of deliveries and from normal deliveries and C-sections and all of that. But I think some of the most rewarding, I remember a mother who, a couple of them, a mom who had quads, who was making change and progressing, and was 18, 19 weeks, and her cervix was dilating, and we were watching it in 20 and 21 weeks, and it was getting worse and worse. And then at 23 weeks, just about the time when babies maybe can survive, she was like 8 centimeters dilated, and the babies looked like they were going to deliver. And at 8 centimeters, it was kind of hopeless, it seemed like, because they were about to deliver. And at 23 weeks then, we didn't think that any would survive.
And 4 babies,
yeah,
right?
4 babies.
Right.
And we went and were able to get her cervix closed, did what's called a cerclage.
Yeah, I heard about that.
Yeah, and did
I haven't. What is a cerclage?
Well, it's a little bit like it sounds, circlage, right? It's basically tying a suture around the cervix to close it back so that the baby will stay inside. So I remember that one, and I remember a mom with a set of twins who had previously lost a set of twins, and she came into the hospital desperate because she was feeling some pressure, and she was like the last time, was about 18, 19 weeks, and came in the hospital, and literally when we saw her, the twin A had delivered through her the baby's head was through her cervix, so the bag of water was out and the baby's head was through her cervix, and amazingly we were able to push the head back up through the cervix and push the bag of waters back up through the cervix and get a stitch around there and keep the baby in there. And she sounds scary, huh?
Yeah, I've been there. I mean, I've watched this stuff firsthand, watching my own kids being born.
Yeah.
And I cannot imagine at that point saying, Ruth, we're going to push it back inside.
Yeah.
Yeah.
Jesus, the hell you are.
Right.
I'm sure you never hear that sort of thing, though.
No, I've been in some funny situations with moms and dads and some funny stories. But in that case, of course, that baby would have been too early. But fortunately, that baby, we kept those twins in, and they went on and delivered near term. But that's mom stuff. Baby surgery, I think we've done sometimes you get a little bit desperate, and moms and families get desperate. We recently had a really neat surgery here, I guess, that it's not so unique in the sense that it's never been done, but we had a mom whose baby was very anemic. The baby had, You've probably heard of that Rh disease, where moms and babies' blood systems are incompatible, and this mom had developed some allergies to the baby's blood type, and so she was making antibodies that were crossing the bloodstream, and she had a lot of them, and so it was happening really early, and by 17 weeks, her baby was very anemic and very swollen, and was on its way out, and we really didn't have much choice, but at 17 weeks, babies really. I can't find record of a baby being given blood in the womb. We do that later when the cords are bigger, but we were able to get this baby transfused, and I can't find record of it having been done that early anywhere in the world.
So if the mom is allergic to the baby's blood, and you're giving the baby new blood, is the mom then suffering allergic reactions at a greater intensity, or?
No, the blood we give is actually cross-matched to mom. So we find blood that is compatible with both her and baby. So it's typically like O negative blood that matches her, and then it won't be destroyed. So if this baby eventually ends up like this baby, for example, the baby we transfused at 17 weeks. The baby, when we got in there, the needle we got a little tiny needle in the baby's umbilical cord in the womb, and drew blood out, and the baby's blood count was 9. So normally babies in the womb are about 45 or 50 then. So we gave the baby some blood in the cord, and then we had to go back and do that multiple times, because every time the baby would make its own cells, the baby's own blood would get destroyed by the mother's cells. So the baby ended up getting 7 different transfusions.
So when you say transfusion, maybe people don't understand. It's not just like a shot of blood. It is a whole body's worth of blood, right?
A big portion of it. So a baby can't take its whole blood volume, because it's just too much volume all at once, because this transfusion's given through a needle that is, fraction of a millimeter, that is going in a cord that is, a millimeter size or smaller in the baby's umbilical vein. So we'll give a portion of blood. Usually I don't give more than half of the blood volume, the baby's blood volume. So that's why you need to do it serially. I mean, ultimately, when the baby's born, almost all the blood that the baby has is from some other human.
Yeah.
Now, I'm thinking that timing has a lot to do with this. You've got to have access to that blood almost immediately, right? So you just pick up the phone and say, I need this and this and this, and I need it stat, right? I mean, is that how that works?
You don't go to the DMV for your blood.
Yeah, thank you.
Well, yeah, I mean, it's Red Cross, find it specific. Sometimes it's very hard to get the blood, because some of the antibodies that the moms make are unusual ones, and so sometimes it's hard to find blood that's compatible. So we appreciate blood donors. Thanks.
We're up against a break, and when we come back, I just want to ask you about how all this wonderful technology and knowledge came to be. Because 100 years ago, we'd have lost the mom and the babies, right? I mean, I want to talk about how this all developed, because you've just studied the history as well as the practice. So we're going to come right back. By the way, if you have a question or a comment, you want to share your story with Dr. Faussett, give us a call at 721-1290. This is Health Talk, and we'll be right back. Okay, we're back on Talkback. I should say Health Talk. This is the special edition of Talkback. Dr. Berdett Faussett is joining us. He's a maternal fetal medicine specialist, perinatologist, and I just asked you before the break, Doctor, to talk a little bit about how all this came about. Obviously, 100 years ago, we would have lost a lot of these moms and babies, and it might even not known why. But now, how did this all come about?
Well, I think thanks. That's a great question. I think it's progress in obstetrics is really interesting, because if you go back and look at, in some ways, we're really slow on purpose to do things, because you think
you don't
about,
want to be experimenting.
You take exactly. Right. Who wants to? There aren't very many moms who, for example, take a new medicine. When we say, "Hey, would you like to take this new medicine?" or would be willing to do a randomized trial and say take a placebo versus a real medicine, and so it's pretty tough to learn about new medicines or to learn about new therapies, and sometimes it really. It takes somebody with just a little bit of craziness, I guess, to experiment a little on some of these difficult situations, I guess. It puts, sometimes it's, there's a guy named Charlie Harrison who started with some of the fetal therapy, for example, from San Francisco. And I remember back when I guess I'm not that old, but I'm old enough to remember when Charlie would get persecuted, I guess, a little bit for experimenting on some things where he was working on, for example, spina bifida, where they were trying to fix spina bifida in the womb and do open fetal surgery because they would have to make an incision in the uterine wall and expose the baby's back and operate on the baby's spine and then close up the uterus and close up the mom's belly and then continue the pregnancy. And there's risk that moms could later labor or rupture the uterus. And when it's a non-lethal condition, especially, people really are anxious about that. And now we've come a long way and found over time with a little bit of courage that we're making a big difference in some of those babies' lives. So,
well, real quick,
yeah.
Why go through all the difficulty of doing that surgery inside of the mom when you give it a couple months and maybe it'll be outside and you can take care of the baby outside of the womb? Right.
So that's the great question. So really the answer is that if you can, for example, with spina bifida, if you can fix it in the womb, they have less what we call hindbrain herniation, because the spine ends up being tethered to the bottom where the spine is open. And if you can fix that early and close that space, then the brain gets buoyed up in the skull more, and so it doesn't pull it down to the bottom of the skull as bad, and they have less shunting. And less shunting means less risk of infections, and they just do much better IQ-wise in the long run. And so survival is no different. In fact, you risk preterm delivery, like you said, by doing a surgery in the womb. But in the long run, if they get through it, that developmentally they seem to do better because you fixed it in the womb.
Wow.
We had, another example. We had another case that was a little bit, again, it's hard to draw the line between what's experimental and what's really trying to help. But we had another case here where we had a mom from Salmon, Idaho that came where she had kidney obstructions, and the baby was not able to empty all its urine from basically the tubes from the kidneys to the bladder were partially obstructed. And during the course of the pregnancy, we lost one kidney. Well, you can lose one kidney and do fine. But the baby had growing obstruction in the other kidney. And it looked like by about 26, 27 weeks that we were going to lose the other kidney. So because of a blockage. So do you leave the baby in the womb, lose that kidney, in which case if the baby's born, then the baby would have to be on dialysis until it could be big enough to get a kidney transplant, which is maybe 20 pounds if you're lucky. And that's a difficult row to hoe. They may not be able to do that. Or do you try to drain the kidney? And so we ultimately, after lots of conversation, decided that we would try to drain the kidney in the womb. And so we placed a shunt, basically a pigtail, a little catheter that had two little curlicues, one on the inside and one on the outside. So went through the mother, through the mother's womb, into the baby's kidney pelvis, and placed this little tube, and then pulled out my little trocar, I call it, and then emptied the rest of the tube outside of the baby's back. And this is the way we drain kidney sometimes is with adults, and emptied the kidney now into the amniotic space. So we drained the kidney. So we left the baby in the womb, and then ultimately when the baby was born, the baby had that draining kidney. And for several weeks after the baby was born, they continued to use that shunt and made a big difference. And really that baby still has a functioning kidney now and is doing great.
I feel like I'm listening to Star Trek here. This is the coolest stuff. I mean, you must really, get up in the morning and your feet hit the floor. Man, I can't wait to get to work. What am I going to learn today, right?
I learn all the time, and that was an example of something amazing. They're just wonderful families I get to work with, and a great group of people. I feel so privileged. I came here 2 years ago from the military after 25 years of it there, and same kind of stuff. But I work with the best people here at community, and amazing group of nurses and docs, and a supportive administration, and great people around great docs around the community that send these moms with courage, and it's just a privilege to be here.
So you deal with a lot of difficult pregnancies. Do you deal with a lot of pregnancies that have complications because of drug addictions, things like that?
We do. That's a big problem now. I mean, in some places in our state, we have as high as 50% of the babies born that are exposed to narcotics or other illegal drugs.
Now, is
50%?
Is there
Some
one
places.
that's worse? I keep hearing that meth is the worst. Is that correct, or are
Well,
there
meth
others?
is bad for sure, and it's common. Probably if you took a drug, an illegal drug that causes the most problems with babies, it's probably cocaine. Unfortunately, we don't see that much of it, now, but by sheer volume, meth causes a lot of problems. Poor nutrition on moms. It causes placental abruption issues, and which is a placental separation sometimes, and high blood pressure, and poor prenatal care, and things like that are associated with it. So there's a lot of that. But even the chronic narcotics, we have a real problem in our society right now with people taking legal drugs, but that are using them long term. And then babies have a lot of trouble sometimes with withdrawal after they're born.
We're going to take a break. When we come back, we only have about 3.5 minutes left, but I want you to give some advice to parents who are anticipating becoming pregnant. And how they can avoid coming to see you. You know what I mean?
That's great. I'd rather see them on the street and say hi, right?
Yeah, we're going to come right back. Stay with us. But you might enjoy this, Doctor. A little baby music for you.
Perfect.
All right, here we go. And I asked you, we have about 3 minutes left in the program. So how about some advice, Dr. Faussett? People are planning to get pregnant. You have the expert right here. How can we make it so it's going to be as safe as possible?
Well, I think probably go ask Grandma because she's probably right. It's practical. It's practical stuff for the most part. And if things are normal, do normal things. The things that you would think about. Be healthy. Get an ideal body weight is great. Good nutrition. Good exercise, so you come into a pregnancy well is really, those things are, I can't overemphasize those actually. And
don't smoke, right?
Don't smoke. Huge deal. We really underestimate that issue. I can't tell you how many people I have right now in my practice, people in the hospital right now up here from places far away in Montana that are here because their babies are so small, and we're worried that the baby may not, they're in the hospital because we're afraid to have them out of the hospital because their babies are so small because of placental dysfunction, because of tobacco use. So, yeah, that's a big deal. And if you have medical complications, actually, you can come see me before. Love to see people before. For example, with diabetes or other heart conditions, come see me before and get tuned up. Be ready to come into a pregnancy healthy. That makes a big difference.
So you don't just do like these insane upside down deliveries and stuff. You do normal gynecology exams and talks and regular birth stuff.
Mostly, I don't really take care of normal people.
Mission Impossible, doctor.
Yeah, but I do get some really neat things. When we were off, we were talking a little bit about women who've had a previous C-section and then had a successful vaginal delivery after. I get to do some of those, for example, and that's fun. It's normal, except for they've had a previous C-section, and that's a wonderful opportunity.
We only have about a minute left. It's not time enough. Can you come back?
Yeah, I'd love to come back.
All the guests you bring us, we want them to come back.
Yes, we would like a second delivery of
second shot.
We have twins.
There you go.
Triplets,
Right.
whatever.
Thank you. If you don't mind, give us some information about how to reach your office. And who you would recommend to call you in the first place.
Yeah, typically, most people come see me through their doctors. Most people, their doctors will send a consult and say, would you see this mom? Because I usually don't take care of people primarily. That keeps me out of trouble. I don't really want to compete with the docs in town or the midwives or whoever's taking care of them.
You can't call Dr. Faussett unless you have the red telephone.
You got to have the bat phone. Just have your docs, or certainly get through community or labor and delivery. You can certainly find me, but most of the time the docs will send you to see me.
All right, and thank you so much for being a part of the show. This has been great.
Thank you.
We really
Thank you
appreciate
guys
it.
very much.
Good information. All right, so that's going to do it for Health Talk today. And by the way, this will be up on our podcast page here in a day or so, and you can listen to it to your heart's content. And we'll be back with Talk Back next hour.